help us understand, Tim, your view of this question that I gave Dr. Donnelly and that Dr. Shank and I kind of agreed on momentarily. The idea of this being a passive modality and patients being a passive recipient and the locus of control issue that came up. Dr. Donnelly handled it fairly well, I thought, but I'm not sure that I'm ready to buy in that can't lead a patient to this fixer and fixee, so to speak. At least it could be an issue. Where do you stand on that?
It is a problem. I think that, when you do something passively in that way, you would, with whatever approach you're using, run the risk of having that develop between the patient therapist relationship. I think it goes in line with what Dr. Donnelly had mentioned, though, recognizing that patient. I think we should be, with experience, pretty apt to recognize if that is that person's tendencies or interest. Mm-hmm. And, you still may decide to do it because there's a person in need. And, they both had mentioned the biggest predictor to a successful outcome is meeting someone's expectations. I don't have probably the opportunity to needle people as readily as he does, because people come to me because they, find me for the McKenzie system. So their expectations are not that I'm going to dry needle them. It does come up here and there, but it's not, I'm sure, not to the the numbers that Dr. Donnelly sees. Mm-hmm. But I believe it. You just need to know when to draw the line and choose which tool you're going to use, and try and guide them to self-care if you can. I don't really find it to be a terrible problem in my practice because, again, everyone gets a McKenzie exam, and I generally would, I may do some hands-on techniques the first day, but it's not going to be a needle. I'm trying my darndest to find a directional preference or elicit centralization if that's what's necessary. And, I may put my hands on someone more rapidly than some other practitioners, but that's in an effort for me to understand their classification within the McKenzie system and to, diagnose the problem. If I'm, if someone comes in with pain to their biceps and they have absolutely no neck pain, and they have, I clear their neck. I clear their neck with repeated movements. I mobilize their neck, to really try and find a comparable sign from their neck, which I feel pretty confident that I do pretty well. And I don't find that. And I move to the shoulder and I do a similar process with the shoulder joint. It seems logical to me to take a look at the muscle and see if there's a taut band. And if that's what I come up with, I would probably still expand my assessment and evaluation at least another visit or two with repeated movements just to really clear the spine. But my running hypothesis would still include that there might, the dominant problem might very well be a taut band. I think you have to be open-minded to that. It is, as Dr. Donnelly pointed out, there's a lot of muscles in the body, and to exclude them as being a potential pain generator, I think is pretty limiting.
Mm-hmm. Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.